Thank you so much, Dr. McAdoo, for taking the time out to speak with us. Now, she's the CEO of Nova Scotia Physician Assessment Center of Excellence, that's PACE. Dr. Keri McAdoo has been the Deputy Registrar at the College of Physician and Surgeon for the past 8 years. In her capacity as CEO of PACE, Dr. McAdoo has been leading the development of the first, or one of the first of its kind, the PACE program, which deals with, of course, the assessment of physician there at the Physician Assessment Center in Canada. A graduate of the Dalhousie University here in Nova Scotia, Dalhousie University Medical School, Dr. McAdoo completed her family medicine residency in Alberta. So specialist, general practice completed here, specialist practice in Alberta, certified family physician, over 20 years of practice experience in family medicine in Nova Scotia. She has contributed to the development of licensing pathway for internationally trained physicians. Her efforts have helped improve access to qualified healthcare professionals within this province. Under her leadership, PACE is helping integrate competent primary care physicians into the provincial healthcare system here in Canada, and in doing so, expanding primary care access for thousands of patients across Nova Scotia. All right, participants, please help me welcome Dr. Keri McAdoo, and I'm hoping that the rest of Canada, as they're listening and as she speak about challenges and those innovative practices, that we can probably extend some of that, not just have it here in Nova Scotia, but extend it to some of the other provinces across Canada as well. Thank you very much. Help me welcome Dr. McAdoo.
Thanks so much for having me. I'm very happy to speak with you today. Thank you very much for the introduction, and I'm happy to go on to the next slide. So PACE is unique. It has a hybrid mission of assessing internationally trained physicians for licensure in Nova Scotia, while at the same time providing high quality primary care. We opened our doors in February, and my aim today is just to give you an overview of why we launched PACE, how we made it happen, what's unique about this model, and where we are today. So the purpose of getting PACE stood up in the first place was to address the primary care shortage that exists in Nova Scotia, and certainly that's a well-known problem here and across the country. I'll talk a little bit about how we got it up and running, the core components of it, making it unique, a little bit about physician eligibility, the evolving practices around assessment, and then what we've learned to date. So PACE is the newest practice-ready assessment program in the country, and the pieces that are unique about it we'll go over in a little bit more detail, but it is a workplace-based assessment, so the physicians that are being assessed are overseen by experienced family physicians trained in assessment specifically. It's in a collaborative care setting, and the physicians that are doing the assessment are well trained in the tools of assessment and how to appropriately assess physicians trained internationally. It is a requirement for licensure in Nova Scotia for most family physicians to undergo a practice-ready assessment if they're trained outside of Canada. There's only 4 countries that the College of Family Physicians of Canada, so not the College of Physicians and Surgeons, but the College of Family Physicians, they recognize 4 countries, their certification, but otherwise the rest of the training needs to go through a practice-ready assessment like this. And so the challenge for many practice-ready assessment programs across the country is finding assessors to help do this work. It's important work, but it's also challenging and difficult work, and not the same as regular clinical work. And so it comes down to what we call the 3 C's for assessors. They want to feel competent, they want a community of practice, and they want to be appropriately compensated for the work. And so this model speaks to all 3 of those things. things. We partnered closely with the Medical Council of Canada, who have provided comprehensive, robust training for our assessors and helped us develop the assessment tools and the platform that goes into it. The PACE model is also centralized so that all of the assessments happen under one roof. And so all of the candidates are together, all of the assessors are together, and all of the patients are registered with PACE specifically. So this allows for the community of practice to develop both for the candidates as well as for the assessors. And then the assessors are also compensated for the work. The clinic doesn't see as many patients as would be seen in a regular family practice because assessment takes extra time. And so all of that is taken into account when we're looking at attracting assessors to do this work. Certainly the assessors were very keen at the program when we had them training in January, and they started the day by describing themselves as Dr. So-and-so from Truro or wherever they may be, a family physician. By the third day of the training session with the Medical Council of Canada, they were saying, I'm Dr. So-and-so and I'm an assessor. So it was clear that they had really felt confident in the work that they were doing, which was key to all of this. So just to give you a brief run of the timeline of things, the Premier announced the opening of our assessment center back in October. We had originally felt that we would need a year and a half to get ready, but the announcement was that we would have the clinic available in January. So that's what we worked on doing. We hired staff and we were given a beautifully renovated clinic facility and had 8 exam rooms. And by January, we began transforming it into a functioning medical clinic and assessment center. The Medical Council of Canada were really nimble on their feet in helping us work for this really tight deadline. And they were able to deliver this assessment training program, as I mentioned, in January. And we had our first 12 assessors undergoing that training in January, and our candidates at the same time were undergoing a new orientation and clinical observership and onboarding time in that same timeline. And that allowed us to be open for February for our first patients to be seen and for the formal assessments to take place. Our first group of candidates graduated in May and are about to enter into practice. So what the key features that make PACE different than other ones are that it is this centralized model. Typical practice-ready assessment programs have 6 weeks in one community with one assessor, or maybe 2, and then 6 weeks in another community. This, as I say, all of the assessors are in one place. So each assessor dedicates 1 or 2 days a week to this work. And so it's a pool of assessors that make up the 5 days a week so that we always have 2 assessors in the clinic each day. It's a dedicated clinic, so it's exclusively designed for both purposes, the medical clinic aspect as well as the assessment center. So it's designed specifically for that type of work. We have rolling intakes in that when a space becomes available, then we bring another candidate in to fill it. We don't have once or twice a year intakes like a lot of the programs do. It is competency-based versus time-based. So once the demonstrated competencies have been shown in the data that we collect, then the assessment can end. And so traditional PRA programs are 12 weeks in length. Ours, we expect to be an average of 8 to 12 weeks and not more than 20 weeks. But it really depends on the individual and it's customized in that way. They are data-driven assessments, so we're collecting a lot of information throughout the time that a physician is with us in the assessment center. And all of those little pieces of data add up to what the full picture looks like for whether a physician's ready to practice in Nova Scotia. The other piece that's unique too is that it has an immediate impact on patient care because our patients of PACE have come off the Native Family Practice Registry, and now they consider PACE their primary care or health home place where they are registered. So they're not registered with an individual physician, it's actually with the PACE clinic itself. So the PACE program is based on these core components. It really is built on the Welcome Collaborative, which is a robust orientation program developed by the College of Physicians and Surgeons in Nova Scotia a few years ago. And we'd always contemplated that orientation program would have a longitudinal component over time. So that's one of the things that we're working on with PACE. With the Welcome Collaborative at the college, it's an in-person orientation offered quarterly. One of the things to allow us to have rolling cohorts meant that it was important that the Welcome Collaborative also be available asynchronously or at a different time online, so that candidates could access this information any time of the year, so they weren't having to wait for the quarter to come up for when the Welcome Collaborative was going to happen. So we worked closely with the college to have an online offering of this Welcome Collaborative. It is also a workplace-based assessment, like practice-ready assessments are across the country. It is seeing patients in real time. The candidates provide the bulk of patient care while they're at the clinic. And it is also a dedicated primary care clinic, as I mentioned. So it has its own medical team and its own patients that are part of the clinic. Prior to arrival, we do have online education that we offer to candidates to review before they come. Either they could be outside of the country when they're doing this online information review, or they could wait till they arrived, whatever was suitable for them. But ideally, they review this information prior to coming. And we also, as I mentioned, have the Welcome Collaborative, which, if it's virtual, can be done anywhere pre-arrival. And on the ground, once a physician is ready to undergo the assessment, they have comprehensive onboarding at the clinic, so they understand how the clinic works, introduced to the staff, understand the layout, and then have some training on the electronic medical record that we use there, which is MedAccess. So they are competency-based assessments. It is data-driven. We're closely monitoring the progression over time. And as I say, it's 8 to 12 weeks. So when we feel we've collected enough information and enough data, then the assessment will end. It could be that it's a shorter period of time, or it could be a longer period of time. The way we describe it is that each piece of data, so which is a direct observation of a patient encounter, is kind of like a pixel of an entire picture. So it just gives us a little picture of one encounter, and we add up all of those pixels to really have a full view of what the competencies are for anyone that's going through the assessment program. So the rolling intakes are possible because we do have the online orientation, we have the just-in-time onboarding, and because we can fill a spot as soon as it becomes available. We're working towards continuous application intake. We briefly opened up our applications and we're really flooded with them, so we had to close it for now until we can get through the number of applications that we have. But our goal over time is to have a continuous intake of applications. The eligibility criteria are similar to other programs in Canada. We don't require the MCCQE1 or the NAC OSCE. At the moment, we don't require TDM. That may change in time. The challenge with the TDM is really a logistical challenge. We do believe it's a good exam. It's just not offered enough to accommodate the rolling cohorts. So it may well change over time that we will require the TDM, but at the moment we don't. So the current eligibility criteria are a recognized MD and family medicine training or GP training, either 1 year leading to certification and recognition plus 2 years of independent practice, or the reverse, 1 year postgraduate training in family medicine or general practice and 2 years of independent practice. So it could the 2+1 or 1+2. If you've seen practice-ready assessment programs, then that will be familiar to you. You also have to have met the English language proficiency requirements at the college, so the policy that the college has, and have to have currency of practice. And the eligibility requirement for that is 450 hours of independent unsupervised practice in the last 5 years. So when we were opening, the LMCC is the MCCQE1, so we don't require that. I see that question in there. We don't require that. It is considered a benefit to have any of the exams in the selection process, so we would add value to having successful results in that when we're looking at selection, but from an eligibility perspective, they're not required. So applicants will typically go to Launchpad, which is a recruitment firm that's helping us with this. And then we have a pre-selection process that we're helping Launchpad with. And then those that are considered to be most eligible are referred to the college. The college then ensures that the eligibility criteria are met, and then they refer eligible candidates to PACE. We then go through another selection process, and those that are chosen will go to Nova Scotia Health for interviews. You have to be legally allowed to work in Canada, so you have to either have Canadian citizenship, PR, or be able to obtain a work permit. The work permit comes, as you may know, once you have a contract from PACE, a letter of offer from the Nova Scotia Health, and the college indicating that you appear qualified for a license. I don't know when we're going to be opening applications again at the moment. So we have hundreds and hundreds at the moment to go through, but we hope to go through those in the next few weeks, and then we will decide what the next steps are after that. So I've mentioned that our assessors, we have 12 of them at the moment. They've had more than 30 hours of training. They've developed the community practice, and they are compensated to work as assessors, not just as the assessor, but as the most responsible physician as well. And the assessors are the MRP, the most responsible physician, the whole time they're in the clinic. So we have audiovisual equipment in every exam room, much like a postgraduate training program would have. There's cameras and audio so that the assessors can view the encounters from another room, which allows for better patient rapport with the candidate. We have daily direct observations, so the assessors review at least 2 or 3 of the patient encounters each day. They review what are called key tasks, which are essentially entrustable professional activities. Same thing that happens in postgraduate training programs. So they look at 1 key task per encounter that they're reviewing, and then they use an entrustment scale that's a 5-point scale from fully entrustable, no intervention from the assessor required, all the way down to unsafe or unentrustable. So this 5-point scale is used for each direct observation that happens, and candidates are provided daily feedback, and they can also provide their feedback. We do make sure that patient safety is considered number 1, so that is an important piece of the work all the time of the assessors to ensure that patient safety is maintained. And at the assessment level, we want to be sure that that's happening ahead of any assessment tools that happen. At the end of 10 to 12 weeks, we have well over 200 direct observation assessment reports, so lots of data points. It's not just 1 data point that makes the decision, it's several over time, and each candidate is reviewed by 6 to 8 assessors, so there's multiple people doing the review as well. We have key checkpoints along the way where we do extra assessments related to professionalism and communication. We monitor progress on a weekly basis with a medical consultant, and a decision is made each week whether to continue with the assessment or how much longer it would appear that there's left to the assessment, so that we can give people as much notice as we can. So these are the 14 different key tasks. They're basically things that a family physician would do in their office in a primary care setting in Nova Scotia. And this is just an example of one of the physicians that went through the program in the past. This is a representation of what the entrustment scale can look like over time. And so the blue color that you see is fully entrustable, and you can see that over time that became a larger number. And so 7% on the last slide on the right shows that they were independent, and the blue is 93%. They didn't require any supervision at all. And that's the trend that we would expect to see over time. So when a physician gets to the end, then there's a competence committee that makes a recommendation to the college. Success in the program will typically lead to a defined license, which means that you can practice independently with supervision. In the rare case, a physician might go straight on to a restricted license, which allows for independent practice without supervision. And in the occasional person, they may be recommended for a clinical assistant license. They can practice on a clinical assistant license in Nova Scotia, but they would require indefinite supervision. And then there's always the potential for a physician not to be successful, and then they would be recommended for no license at all. Next slide. So when we look ahead, we're looking at our governance structure for PACE and how that will look. We're looking at expanding our physical footprint because we need more space to allow for more assessments to happen. And when we have a bigger space and more assessors, then we can accept more candidates and we can accept more applications. And we're actively working on that now. We're looking at expanding into other disciplines. Specifically, we're looking at hospitalists in the future. And we may well have other primary care clinics while we're looking to get into the bigger space. We might have interim space in the meantime. And then as all of these programs, we will be doing a program evaluation with the Medical Council of Canada. Right now, at our current physical space, we're only able to accommodate 4 or 5 candidates at a time. And when we get into our bigger space, then we will be looking at 10 to 15 candidates at a time. And so we really are keen to get some interim space. When we do accept applications, the first point of contact is with Launchpad. So when you go on the PACE website, there will be a place to apply, but we don't have that open right now because we have too many applications that we need to review at the moment. And then when we open it again, it'll be on the PACE website. So essentially, PACE reimagines the practice-ready assessment. It supports patient care, ensures patient safety, and we certainly have required lots of collaboration with partner organizations. We're very keen on all of the data that's collected, and we're continuously improving already. I appreciate your attention and your time. You can stay tuned with our website, which is where the application will be. When we're open for applications, it'll say that again.
Okay, awesome. Dr. Keri McAdoo, thank you so much for this awesome presentation.